don't mind. So, Professor Andrea Kwa, as you've gathered, she's got a very busy life as a clinician. So we're very fortunate for her to join us. She's a pharmacy clinician scientist and assistant director of health services related research at the Singapore General Hospital. She's also an associate professor of emerging infectious diseases at the Duke NUS Medical School. So with no further delays, we might get you on to present, Andrea. Thank you.
Thank you for the kind introduction. All right, so sorry for the hiccups in the technical side of things. Okay, this is my content. I'm just going to go through the antimicrobial resistance in the region in Singapore and what is our approach together with TDM. So some stats from my institution: we are nearly 1,800 beds, acute tertiary care with more than 40 clinical disciplines, highest proportion of patients who suffer from high-risk complex multiple medical conditions. They are usually older, and with long list of comorbs, require long period of stays. The AMR in this region. So you can see that actually we are about between 5 to 10% of CRGNBs, whether it's ABAL or antibacterials. But for ABAL, of course, is much higher. It could be more than 60% or between 50 to 60% when you talk about carbapenem resistant Acinetobacter baumannii. So we know this is something that's not new to us, even though there are some new antibiotics coming. But bear in mind that I just got to know earlier this year that cefiderocol is not going to be marketed in Singapore and in the various parts of Asia, except in China. So for Singapore, we have a lot of resistance issues, all in the regions of, like, for carbapenem resistant PA is about 24%. For ABAL is about, say, 70% and above, and for CREs is about 12-15% currently. So we have a national survey of CPCRE performed by CAPES between these 5 years. And we found that we have all kinds of different types of carbapenemase productions, as well as dual carbapenemase producers. And we also do see non-carbapenemase producing carbapenem resistant antibacterials. Anyway, it's just going up. So this is what I've meant. And in recent years, KPC has overtaken NDM. All right, not much. So right now we have a good equal mix between KPCs, NDM, and OXA48. So according to the HAIPPS that we've done quite a few years back, we do have all these stats. Our MRSA is like out of the staff is about nearly 60%. But our MRSA rate has dropped drastically because of good infection control. Our ABAL rate has started to come up a bit. Now, actually, for this past 2 years, what is climbing exponentially is actually our CRPA. I've said this before, so in our antibacterials, co-producers are found with KPC, NDM, OXA48, NDM, and 232 with NDM, 181 with NDM as well. So NDM is a good friend with other types of carbapenemases. So we do have quite a lot of Klebsiella pneumoniae type of STs. These are the various STs. We do not solely have ST258. Even if we have ST258, they are not carbapenem resistance that high. So that actually describes our epi within this region, which is actually quite distinct or different from what we have seen in North America, Israel, and Europe. So how about us in SGH? We have about 423 clinical isolates, and we have tested them for MICs. So these are the epidemiological spread of our carbapenemases and those without carbapenemases as well. So our CZA is pretty good for KPCs, and for OXA48, as well as for the non-carbapenemase producers. So we have promising options for non-NBL CREs compared to other last line of salvage therapy, but we don't really have good last line for NBL producing organisms. So we have this approach, what we call in vitro guided antibiotic combination therapy. So we do acknowledge that when we ask for culture and susceptibility testing and the report come back as everything is resistant, sometimes including polymyxins. So what do we do? Then they will ask us for help in this. So we did perform a lot of in vitro combination studies on extreme drug resistant, even pan drug resistance PAAB. All right, so in all of these studies conducted, okay, we show that there is no one magic combination that will hit all XDR PA, AB, or even antibacterials despite having the same species, genus, family, and clonality. The reason being, you know, the human body is not just having one type of bacteria. When some don't show, it's not culturable. It doesn't mean it's not there. But when you use antibiotics, certain resistance pathogens that is already there will show up. So every individual is different because the host can be different. So we have performed hollow fiber infection models on this as well. Same thing, no one magic bullet that hit all XDR antibacterials despite species, genus, family, and clonality. So there are a lot of combination antibiotics versus polymyxins or versus some monotherapy for resistant infection. Actually, it is a bit, to us, it is a bit useless or futile because there is actually no one magic bullet that can hit your resistance if they're carbapenem resistance. Which is why we feel that the in vitro combination testing is the way to go. Since combination therapy has been proposed as best practice in the treatment of CRGMBs because there's really nothing else to use. So the ideal antibiotic combination should be, all right, strain specific because no one bacteria behaves the same way and no one patient will have the same types of antibiotic exposures in her patient journey. It should be selected based on the site of infection, PK profiles of each antibiotics and ability of each antibiotic to penetrate the sites. So the doses have to be based on PK/PD optimization. We should be able to leverage from some results from in vitro/animal models, but animal models are very expensive to do. And it should be available to clinicians in a timely manner. So that's why we thought of doing this prospective antibiotic testing service. So we have developed a method, and this method is to guide the selection of rationally optimized combination therapy, taking into account the in vitro combination testing results of each strain and patient's PK parameters. So on day one, all right, the patient may have a resistant isolated, and whereby the culture report, the culture susceptibility reports are totally useless because it's not telling us what can be used. So then we'll get a call and we will have to start performing this combination testing for the physicians. After we incubate the bacteria on the day that we receive the bacteria, 18 hours later, we could let the physicians know what is the at least inhibitory combination that the patient can possibly use. And give us another 18 hours, we will be able to let the physician know that what are the CIDR combinations, not just synergistic, but synergistic and CIDR. CIDR means 3-log drop from baseline. So this is a sample of the report that we will give to our doctors. We will let them know what is the basis of why we choose certain combinations from this testing. Because bear in mind, when you perform such testings, we do have like 20 or 30 combinations possible. So, but we don't have to recommend all the 20 to 30 because we know some of them will never meet at the site of infection. So we will only recommend those that we know will meet. All right, so these are the recommendations that we give. Even up to the dose, we will individualize the dose for our patients because taking into considerations of the PK status and the fluid dynamic status of that patient at that point in time. So we will ask these 14 questions. before we will suggest the combinations. So usually it's done in the broth microdilution method, carried out in 96 microtiter wells. They can contain single, 2 drugs, and 3 drugs in combinations. These are kind of validated in our time kill and hollow fiber infection model. The concentrations that we use are simulated using clinically relevant unbound concentrations. Bacterial load, usually we start between about 6 log now. We have tried to challenge the method with better, higher inoculum recently. So the endpoint is bactericidal activity, which means 99.9% decrease from the initial inoculum. So this is the amount of plates we have to plate to know which one are bactericidal. So that's one combination testing, and we will need to be able to give the correct dose to the patient so that we know they will be able to achieve the correct levels that we have simulated in our plates. All right, so antibiotic dosing, this is something that I guess the speakers have already talked about in many of their presentations. I'm going to skip it a bit. So TDM in antimicrobial resistance is very important because of our combination studies and the antibiotics that we use in our combination. So we have decided to come up with an assay that incorporates the therapeutic drug monitoring of these antibiotics here that you've seen here. So currently it has been accepted already, this manuscript. So one assay run, we will be able to know the quantity of these antibiotics. So in our recent BLAST2 study, is a prospective single cohort observational study where we look at the proportion of patients with suboptimal beta-lactam levels. But while we assay their beta-lactam levels, we also know their fosfomycin levels, their tetracycline levels, and so on and so forth, because the same assay can actually detect all these levels. So this we target populations of patients who are sepsis, with and without dialysis. So after we got the levels back, we will actually sort of report it as well, let the doctor know, and the doctors will then use with us in consults. They will up or down the doses as needed. All right. So for example, we have for combination therapy, we have performed this in vitro combination assessment, and we found that for this certain patient with MDR, Achromobacter pneumonia, all right, that if you give piptazole at this dose over 2 hours, levofloxacin and fosfomycin in combination, we should be able to eradicate this bacteria. So currently he has AKI issues. His urine output is as such, all right, and then we just state down the MICs of this organism. All right, and then we have the levels here. All right, and from these levels, we know that we are pretty comfortable to know that these levels are actually very close to what we have simulated in our plates, or even beyond or higher than what we have simulated in our plates. All right, these are fosfomycin levels. So this time point, as far as possible, we try to make them do the time points that we want, about 4 or 5 time points along a dosing interval. But at the same time, we want to make sure that it's also convenient for our team, all right, the nurses as well. So, but at the end, whatever levels that we have, we will put it through our P metrics, and we will actually simulate the result as such and calculate the VD clearance and half-life for our doctors. Okay, so this is part of the report that we'll give to them. So it's act as an educational piece to educate them about how important levels are and look at the numbers that were hit. And this patient actually got discharged with no issues. There's no antibiotics ADR, so which means that for some antibiotics, the therapeutic window is really, really good. All right, so anyway, moving ahead, we are looking at drug levels, accumulations in other biomedium like feces, in abscess, in the bones as well. And we are also going forward with fudge plus antibiotics in combinations. And we are looking to build up a easy kind of lab-developed technique platform for our in vitro antibiotic combination testing, so that we can roll it out to the countries around us, because they are the ones who has much higher resistance than us, and we are a porous country. We do have several studies on outpatient OPET, so that we are able to dish out more antibiotics for OPET use. The end. Thank you so much.
Thank you very much for that, Andrea. It sounds like there's a lot of challenges that are going on in your hospital with obviously using very different therapy. The phage therapy is going to be intriguing. And so I hope you can maybe stay online until the final presentation, so that you can be a panelist together with the other online panelists, Claire and Jan Willem. So that if there's any questions that are coming your way, there's certainly some questions that I can think of, so that we can have some question time after the last presentation. So thank you very much for that.